we are going to be tuning into some questions from the audience. Dr. Othman, we had a question about the best lifting agent when you were talking. What do you prefer? What are the characteristics of a good lifting agent that you use or look for?
Yeah, so it has to be cheap because we use a lot of it. That's number one. And I would say anything like a starch-based would be good. I know in the market we have many lifting agents that are commercially available, and I use them for EMR. And the rationale is if you are doing a screening colonoscopy and you encounter a polyp that's 2 centimeter and you don't want to go get methylene blue, the vial is $150, and then you are going to open it to remove a lesion, it's not worth it. Then you can use one of the commercially available one. It will be less than $100 in price, and it will give you a nice lift. But if you know that you're going to do a whole day of ESD and you are going to use maybe 400 cc's of liquid, then it's better to use something like Hispan, which is methylcellulose, and you can get the methylene blue, and you can mix your bags for the entire day, and it will be very cheap if you count it. So for large volume, you may need something that's, I would say, economic. But for the first time use, or if you're still in your training, it's okay to use one of the commercially available one. I don't have a particular one that I like, but I noticed that some of them will make a lot of bubbling during ESD. And this is another reason that I use a starch with methylene blue.
So I do want to just take one other question. And I think the question is, what are the lifting signs? And I think it may be also relevant to say what are non-lifting signs. So if anyone from our panelists wants to take that question about what are you looking for when you see a lesion, which tells you that there could be non-lifting, and how you approach it. I think, Mohammed, this may be something you can get started, and Amit, you can chime in as well.
Yeah, so the first thing you notice is that if you inject around the lesion, it gets more depressed. So you know right away that the base is fibrotic. So the surrounding areas start to raise and the middle start to go down, and you inject more, and then the surrounding get higher up. And there's no way you can do EMR in this. That's why ESD would be important in this non-lifting lesion. And this could be just a simple scar. It looks like the volcano opening. So that's one of the most common things you would see when you inject around non-lifting area.
Yeah, absolutely agree. I think the concern of non-lifting sign is that sometimes it represents deeper invasion of the lesion or invasive component. But here in the US, where most of our lesions are biopsied, APC'd, maybe some EMR done before it gets referred for resection, non-lifting sign could just be fibrosis during the procedure. So for us, it's not a reason to stop, advancing with endoscopic resection. We more look at the pit pattern, other depressed areas to see if there is invasive component. If there's pulling of the folds towards the lesion, that's another concern that there could be invasion. Also, during dissection, especially with larger polyps or bulky polyps, sometimes you'll see muscle retraction. This is where when you are dissecting through the blue, you can see the muscle there being pulled up towards the lesion. And that's actually a very dangerous sign, and dangerous to continue ESD in those cases.
Thank you. I'm just going to go along the same theme if I can. So you rightly said, most of us see patients where they are referred to us for resection of a polyp, but the polyp has been worked on not once, maybe more than once elsewhere. Either they've done a partial resection or there's a tattoo that's extending right into or under the lesion. So now we've looked at all these different tools that we have. I think Dr. Aihara is not able to join us for this Q&A. He's going to be with us later. So maybe for this panel, the question is, if you have a patient referred to you with a previously worked on polyp, and you look at it and you see parts of the polyp have been scarred, and there's you know that this is likely to be fibrosed and scarred, what's your approach, and which of these devices do you use So we can, we have some time. So maybe we can again start with Dr. Othman. Dr. Bhatt can go next. And I see that Stavros and Ken Chang are on the line as well. So if they want to chime in, that'll be great as well.
Yeah, so I feel in the United States, this is the most common scenario that somebody removed the polyp and sent it to you. So unlike the Japanese experience and Asian experience in general, we'll get more polyps that are scarred and fibrotic. And that's why tunneling techniques may be challenging in this situation. My opinion is in the United States, in order for us to adopt ESD, there's two things we have to do all the time: stability in the colon and traction everywhere in the GI tract. Traction is a secret here. Having multiple ways of doing traction, depending on the location of the region, will be an important. I would definitely now would utilize traction for all these lesions. And I would work a little bit further far away, use the traction, and the traction has to be dynamic. And the device that Dr. Bhatt can talk about is amazing for that. But other form of traction is better than no traction, in my opinion. And for a lot of US endoscopists, to adapt doing ESD, I don't think they will feel comfortable doing tunneling. They would do traction much better. That's my opinion.
I absolutely agree with Dr. Ott that I think actually one of the biggest challenges of colon ESD in the US is our pre-intervention on these polyps. There was a great talk done by the advanced endoscopist for Memorial Sloan Kettering, where he looked at his outcomes of ESD in Japan, where he was getting 90 plus R0 resection en bloc. And when he came to the US, these numbers actually dropped into the 70s. It wasn't that he became a worse endoscopist, it was just the lesions being referred to him had been tattooed, scarred, and became much harder resections to do. So I think one of the biggest things that we could do to improve sort of polyp resection in the US is actually education, that we don't have people partially EMR or tattoo polyps before sending them for resection. And so regarding the polyp that comes to us with fibrosis or scarring, I agree with Othman. It's an exciting time to be in ESD. We at the beginning, we didn't even have fluids that we could inject when we were using eye drops. And now we have a total slew of devices to be able to use. And I think I really look at a polyp or look at a lesion and decide based on that lesion, what's the best technique to use. And so these traction devices give us options. For instance, for GE junction tumors, I like tunneling technique. Sometimes using traction devices can actually move the lesion into a harder location. I think for more larger complex lesions, which will need dynamic traction that can be changed throughout the procedure, I think these over-tube technologies are fabulous. For smaller lesions, I think the clip traction wire, those are a perfect solution.
Thanks, Amit. We also have a question about if you guys routinely use epinephrine with your lifting solution, or what are the pros and cons of adding epi? Amit, if you want to take on that.
Sure. I actually look forward to see what Dr. Altman says as well. So we don't. So if I would rather a blood vessel bleed during the procedure and me coagulate at that point and take care of it. My fear of using epinephrine is it's going to cause constriction and maybe less bleeding during the procedure, but maybe those vessels open up after the case and there would be post-polypectomy bleeding. I don't know of any evidence towards it, but that's our practice.
Yes. For me, actually, I have been going back and forth, and it has been a very confusing topic for me because I will tell you that initially I adopted the idea. It's like I had changed my opinion 4 times. So first one, I took Dr. Bhatt's opinion and said, I would rather see the blood vessels. But then I discovered that I have more bleeder, especially in the stomach and esophagus, that spend longer time doing the procedure. Then I said, okay, I'm going to do epinephrine and do closure, because maybe if I close, I don't have the risk of bleeding. But then in the colonic ESD, I start to notice that this patient have pain. So I start reading in the literature, and it turned out that epinephrine, because it causes spasm, it increased the pain in these patients. So when we talk about post-resection syndrome, it is more like epinephrine. So recently, I just accepted one of the case report at the focal point in GIE. They did EMR, cold snare EMR, but in the solution, they used epinephrine, and the patient got post-resection syndrome with pain, fever, and everything. They did not use coagulation here. The only thing that could point out to the problem is epinephrine. So finally now, I stopped using epinephrine in all chronic because the bleeding is small, so I don't use it anymore. I will use 1 cc in 500 bag in the esophageal and gastric, and maybe I shouldn't use it at all. But I'm just telling you like my evolution towards not to use epinephrine over time.
I think I would warn the audience as well that it's funny. We always get these comments from people who come and watch us. Like they would come and say, "But I thought you did this like a few months ago, or like last year. I watched you do this, and you were doing this." It was like, "Well, I changed my mind," or thing. And that's I think where Amit points come to. To reality is like it's a really dynamic field, and that's what we like. Every day we're doing something different. We're thinking, we're trying to improve this really not easy field, which makes it really exciting.
Right. So Hazem, I would say something along similar lines, that when I used to do POEM and GPOEM, I never used epinephrine, and I wanted to see those vessels bleed, and I wanted to be comfortable that I stopped it so that I can sleep well after that. And then Hiro came to our course some year or two ago and converted me, and I started for my ESDs adding epinephrine into the solution. And we've now been using that. I think Hazem, you use epinephrine in your injection solution as well. So we've changed, and what Hazem said is right. I think our world is so small in the line of work we do that it's always the best thing is to have this open communication, where we may not be doing the same thing every month, because we might talk to someone and try a different technique and see which one works in our hands. So I think there's no real right answer, but just to keep an open mind and talk to people who've done more than what you have done or have more experience in a certain area.
I would also, thanks Mihir, I would also point to what Dr. Othman was saying, that sometimes this epi-related pain can be really severe in recovery, and could be many people who have not seen it can confuse it for perforation. Generally, like you really need to use heavy narcotics, and usually takes care of it, but you may need to use that for a few days, and usually takes care of it if there are no other signs, concerning signs for any post-procedure complications. We have another question. I think, Dr. Othman, it's all coming back to you about this C-shaped incision that you introduced a while back, and when do you use it? What do you, when do you prefer to use that in esophageal ESD?
I use it mostly for my ESD, but I'm going to say that it's as effective as tunneling. Like if you tunnel, you have opening the anal side and oral side, and you tunnel, it works. The only problem that I notice, if you are tunneling and you have more than 1/2 of the circumference of the lumen, the tunnel is very hard to complete it at the end, because then you'll need multiple tunnels and you need to connect them and you need to go from the sides. But I use C-shape, I would say, for all my cases. And we're going to publish our data about that in 40 esophageal ESD that expedite the dissection. I would like to hear from Amit, because he's the expert in esophageal ESD. How do you do it?
I'm very interested to see that you use C-shaped incision ESD. So it's actually the way they perform esophageal ESD at the National Cancer Center, and especially for esophageal lesions. So the problem with doing circumferential incision for an esophageal lesion is you dissect, the lesion starts to retract back, and you start losing orientation, tension on the lesion. So if you keep one mucosal border intact, complete the submucosal dissection, the lesion keeps its orientation. So I think it's a fabulous technique. You choose the mucosal border that's gravity dependent, or I do. It'd be interesting to hear what you say. I mostly dissect the gravity dependent mucosal border first, because it retracts the lesion away from the water pooling and enhances visualization.
Yeah, so and you know, we have very similar experience because I also went to Professor Saito around maybe 2015. So I will say that if you dissect both sides to get everything in one plane, so instead of like if you have 2/3, if you get it really to be less than 1/2, so not only do an incision, but incision with submucosal dissections in lateral sides, enough that when you have the C shape and you start dissection, the entire lesion will go with the gravity towards the stomach. So instead of being in one side and interfere with review, it will just keep going down and actually make the esophagus expand and wider and create traction between the cab and the insufflated air. Everything will be moved away to the stomach, and you work from right to left, left to right to get all the margin, and then all of a sudden it's almost like you're peeling it toward the stomach. So it creates, although the patient in left lateral position, the gravity along with the insufflation and the cab will push the lesion towards the stomach as if you are doing traction.
Great. I actually also agree with your concerns about tunneling. I like tunneling, I use it, but sometimes for larger lesions, after you're done, you're going for the final mucosal border. It can be very difficult to have control and visualization and making sure that you're getting that negative margin.
Yes.
Thanks, Amit and Mohammed. I was, I would also say for people who, some of us who perform POEMS and ESD, you can see like here how strategy is a really big deal when you plan for ESD, and it's things you have to take into consideration: gravity and the site of the lesion, proximity to like landmarks such as the EG junction, fibrosis, the invasive part of the lesion, the difficult and the easy part of the lesion. So certainly when you start this doing the homework, and many of us usually go into the ESD procedure having kind of a plot. How am I gonna start? Where am I gonna go? And where is this gonna end? And that's, I think, a good recipe for success. We have one more question. I would like to get your opinion, Dr. Athman and Dr. Bhatt, on this. Is what is in the cecal lesions where it's pretty vascular as well as a very thin wall. What is the best traction method, if any, that you use? Dr. Athman, if you want to start with that.
I think in the colon you can use anything. You can. I feel like the easiest one is rubber band with clips. The device from Medtronic is perfect for that area too. I also use the Lumendi, the Dilumen, but if I'm using it, I use a counter traction. And we are talking about traction. There's two types of traction. Dr. Bhatt showed it in the video, how he used the counter traction towards to the front of the lesion, and you go under it. In the cecum, I use a lot of counter traction rather than traction, which is that you use the traction towards the ascending colon and you dissect in the counter traction side. That's also create enough tension and it's much better. So for cecum, use any device that can create counter traction would be the best.
Yeah, I agree. I think especially for cecal lesions, counter traction is necessary to do safe ESD in that location. I think if the lesion is well defined in about 4 centimeters in size, I think clip wire or clip rubber band traction is perfect for it. I think if it's starting to go over the ileocecal fold, I'm thinking that there's going to be need of change of direction of traction throughout the procedure, then I like the overtube technologies.
Thank you, Dr. Bhatt and Dr. Athman, for this fantastic panel discussion. Unfortunately, Dr. Ihara could not join us, but he will join us later. I want to again thank you guys for fantastic talks this morning, and our audience as well for joining us and with all these excellent questions. And I want to also say that free registration and the credit for this course would not have been possible without the generous support of our sponsors. Please visit the virtual exhibit hall during the upcoming break to learn about the latest offerings from our sponsors. I think we're going to take a quick break this morning, and please return to the webinar by 9:40 when we will start the session 2 on endoscopic myotomy. Thanks, everybody, and we'll see you soon.